Good afternoon. Welcome to Bariatric Friday. My name is Kemal Erkan. I'm the chairman of American Surgery Center. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. How are you today?
Good, very good. So we are going to discuss another topic today, resolution of comorbidities with bariatric surgery.
Yeah.
So I'm going to actually bring my videos. And Dr. Irgau, as you know, we are part of this for a long time now. What we do is pretty similar. So we are discussing these topics one by one each week, so it's not overwhelming for our patients. And when it comes to resolution of comorbidities, actually, can we start with describing what comorbidity is? Because it's a little bit technical term. Some people
absolutely. Literally, comorbidity means a disease that tugs along, right? A disease that hitchhikes with another disease. That's what comorbidity means. Essentially, if there is one disease process, and then if very often you find another disease process that goes with it or is attached to it, we call it a comorbidity, essentially. And of course, we are talking about morbid obesity today. And the fact that we are addressing comorbidity really goes to the heart of our current definition of obesity, right? Obesity is no longer an appearance issue, an issue of, how I look or what kind of clothes am I going to wear. It goes way beyond that. It is actually a medical condition. And it's a medical condition not just by itself, but it's actually connected to many other illnesses that pop up once a person reaches a certain weight. And as we've said many times, what is obesity? What is morbid obesity? Well, it is defined by the weight of the person. If the weight of the person really goes up by about 100 pounds over their ideal body weight, that person's weight now has reached the level of morbid obesity or clinically severe obesity. And as we've said before, sometimes as healthcare workers, we define this by BMI or body mass index, which many people may be familiar with. And BMI really is another expression of the severity of the weight, because what we do is we take the weight of the person and the height of the person, and we have a formula that puts these two together to give us a BMI, the body mass index. So we know, for instance, there is a normal body mass index associated with a healthy weight that happens to be anywhere between 18 to 25. So if your doctor calculates your body mass index and say, hey, your body mass index is 24, it means you have a very healthy weight, right? On the other hand, if the body mass index goes up between 25 and 30, we talk about the person being overweight. If it's 30 to 35, we talk about the patient having class 1 obesity. If it goes between 35 to 40 now, we talk about class 2 obesity. And then when it's over 40, then obviously it's the most severe type of obesity. We call that morbid obesity. And as it happens, morbid obesity is also the level of obesity that qualifies a person to have surgery to address obesity with a surgical treatment.
So the most common morbid obesity, comorbidities for morbid obesity is hypertension, heart disease, diabetes, sleep apnea.
Yes.
But these can happen without morbid obesity as well.
Absolutely.
Makes it like which starts first in these cases?
So, of course, you can have a person who is very thin and they have diabetes. Of course, you can have a person who's very thin and they have heart disease or hypertension. And very often these are related to genetic factors more than anything else. But when we take heart disease, high blood pressure, diabetes, currently in our population, in our society, it is by far the type of disease related to morbid obesity, right? And how do we know that, Kemal? We know that because there has been a parallel increase of obesity and the prevalence of these diseases in our society, right? So if you go back to the 1960s and 1970s, the level of obesity in the United States, Kemal, was about 10%, 10 to 12%. This is, if you go everywhere in the United States, people with a body mass index greater than 30 would be about 10 to 12%. Now it is 35%. And along with that increase in the incidence of obesity, we've also seen an explosion in the incidence of high blood pressure, cardiovascular disease, and diabetes. So yes, of course, you can have those diseases without obesity, but the type of those diseases we have currently in our society by far are related to obesity. That's why addressing obesity makes a lot more sense than us chasing each disease on its own, because it's inefficient, it's very costly, right? And the results are not as good. Why not address head on the root cause, which is obesity currently in our society?
What we find in our daily case conferences, when patients start, they don't even sometimes know that they have these conditions. True. So how many times we diagnose people with diabetes because their A1C is like out of control. They have sleep apnea, and then they think that they're just snoring, but no, they do have sleep apnea. And then we have so many patients, we actually diagnose them at the time of after the initial consult. So the awareness of these issues, like do our patients know that they have these conditions, or do they get used to having them so that they don't actually feel the issue anymore? Because if they didn't come for this bariatric surgery consult, they wouldn't maybe find out for these issues for a long time.
Absolutely, absolutely. If appropriate tests are not done, very often patients will find out that they have these conditions when those conditions have reached an extreme level of severity, right? So it is not uncommon for patients to present with a stroke as a consequence of high blood pressure that has been going on for too long and has reached severity now. Because, as you know, high blood pressure does not give you any symptoms unless you measure it. You do not know that you have high blood pressure. But then when the high blood pressure has been going on for so long and it's severe, it could suddenly give you a stroke that could give you debilitated, right? So those diseases sneak upon patients in a very, very, very dangerous way. But also, Kemal, if you think about it, obesity itself also sneaks upon people in that way, right? How common is it for a person to look at themselves in the mirror every day and not realize that their weight has reached very high levels? Very often, they kind of lull themselves into thinking, yes, they've gained weight, but it's not that severe, right? And then symptoms start appearing, right? Somebody may have struggled a little bit with weight and they've doubled with some diets, but then over time, the weight actually, whether it's 5 pounds or 10 pounds every 1 to 2 years, it accumulates to levels that are very high. And perhaps their first presentation to their doctor may be, oh, I have knee pain now when I walk, or I cannot breathe well when I'm going upstairs, right? So the doctors will see them and they have postponed this for a long time. And maybe their blood pressure is being measured for the first time then. And then bingo, the blood pressure is skyrocketed, right? And the doctor may do blood tests at that time and find that their A1C is also very high. Now they have type 2 diabetes, right? And the doctor may ask them about their sleeping patterns, and they may say, look, it's been that I don't sleep very well. I fall asleep during the day. I take naps very often. And my partner tells me that I snore like there is no tomorrow. And they do tests, and suddenly now we find that they have sleep apnea. And at that time of evaluation of their high blood pressure, they may have an echocardiogram, and the echocardiogram suddenly may show that there is weakness of some of the chambers of their heart because heart disease has also developed, right? So suddenly a person who may be middle-aged, who thought of themselves very healthy, except the fact that they have a little bit of weight, suddenly they find themselves confronted with the fact that they have to take so many medications and they have to go to so many specialists, right? And what is the key here? The key is that the weight has crept up on them. And then the other interesting thing, Kemal, and this is also very human and natural, is that people are afraid to weigh themselves because they kind of are worried to find out where they are.
No,
So
I'm one of those people.
we all are, right? Come on, to some extent, right? Because we don't want to see that scale, right? And then when they see, and then their doctor will say, look, you actually have morbid obesity. You may be a candidate for surgery. And they say, what are you talking about? Surgery for me for weight? Because they associate bariatric surgery only with, my 600-pound show, that show where there are people who really are extremely obese and they undergo surgery. And yet they are actually the ones who may benefit now because they've crossed that threshold of obesity where now they have developed all these illnesses. And then the more you talk to them, actually, the more you find that there are many other illnesses. They may have migraines. They may be feeling depressed because of the way they feel and the fact that they don't have energy and the fact that the weight may be affecting their relationship now, right? They may have heartburn. They may have fatty liver disease, right? They may have gout. They may have other joint problems, back pain, all a constellation of symptoms come out that are all related to obesity.
So I'm going to share my screen for a second. And normally, we kind of shy away from that, but just for this purpose, because I want this image to be understood very well. When we talk about resolutions of comorbidities, we're not talking about like some issue being maybe resolved, maybe not. The percentage of the resolution is extremely high. And so this is what I wanted to share with our audience so they can kind of actually see this. Now, when we look at, and I'm going to actually, 1 second, so where's my, right, so I'm going to use this guy here. All right. So when we look at type 2 diabetes, so this percentage is 83% of the time this is going to be resolved. So that's extremely high. So then I go to like sleep apnea, and 74 to 98% range, this issue will be resolved. So then we look at the cardiovascular, the third common one is 82%, and the hypertension is between 52 to 92%. So these are kind of like, we kind of now know them, but the percentage of the ratio of the resolution is extremely high in a positive way. But then we also see other problems here, right? So then, like, I always talk about depression in our sessions with like many of our patients. They do need to get a site clearance because they do have depressions, like the migraines, 57%. So let's see, the hypercholesteremia, like this is at 63%. The reflux is 72 to 98%. So, and the mortality, 89% reduction in 5-year mortality. So this is probably a doctor wrote this. I would probably write it in a different way, but it's not reduction of, like, it's a good thing it's here. So you are actually improving someone's lifespan.
Yes.
So then the quality of life improvement is 95%. So all these percentages, and I didn't make these up. So this is from I believe the NBAI, right? So this is an official document actually. Mm-hmm. So when we have this level, now I'm pretty sure many people don't really know this will be the result for them. So then I can see some of them who are not actually. That's why, like, as we always talk about, like the utilization of bariatric surgery, which is the most effective way of treating morbid obesity, is only 1%. So if I were to see this, and if I have the issue with morbid obesity, I probably I wouldn't think about it twice. But there's still some pushback from some patients, even from some practitioners. So they don't bring this up. So when I know that there is so much good out there for getting this problem taken care of, I have a little bit difficult time to understand why there would be that pushback. Anything you would like to say about that?
Of course. So, I mean, that diagram that you showed, Kemal, and I've always told you, is one of my favorite diagrams, right? It's from the Cleveland Clinic. And really what it shows is something very striking first, right? And that is there is almost no organ in the body that is not affected negatively by obesity, right? I mean, you're starting, when you mentioned migraine, Kemal, you're starting from the head, right?
Yeah.
And you're talking about gout, you're ending with the big toe of the foot, right? And then in between, you've gone through each organ system, and you've showed that obesity somehow is making all those organs diseased.
Yeah.
And what we're saying right now is, yes, you can do an itemized reduction of the illnesses by going to the doctor and say, okay, I will get a pill for diabetes. I'm going to get a pill for high blood pressure. I'm going to get the CPAP machine for my sleep apnea. I'm going to get medication for reflux. I'm going to take medication for my arthritis. I may go for a knee replacement for my joints, right? So you are doing a plethora of interventions that, yes, by themselves, obviously can be taken care of, but as long as the engine of those diseases with obesity remains present and prevalent, even your individual approach is bound to fail, right? What is a good example of that, Kemal? The good example of that is the progression of hypertension and diabetes on somebody who remains morbidly obese, right? We always see in our case conferences, as you mentioned, a patient who actually may be already on medications for diabetes, and yet their A1C is going up, right? And why is that? Because their obesity is getting worse. So as the time passes, the diabetes will require more and more medication. So they may start, for instance, with their doctor telling them, okay, we'll give you this tablet for diabetes. Okay, now, a while later, they will say, okay, we have to add another medication. Now we have to add insulin, right? And when you're treating insulin, type 2 diabetes with insulin, you're not helping their weight, because with the insulin, the weight may go up as well, right? Similarly with the high blood pressure, right? You start with one medication, it's not enough. You go to an additional medication, it's not enough. Sometimes we see patients who have 3 or 4 medications for high blood pressure, right?
And they're usually not with the high blood pressure. So because of our other case conference, ACO, the accountable care side, I sometimes come to you, even though it's not a bariatric patient, that PCP is managing 12 different medications. And because they have diabetes, hypertension, and let's say kidney, or diabetes, hypertension, and psych. So many, like it's so common these days, patient has 7 to 12 different medications. And then
Absolutely. So if you look at all these diseases by themselves, Kemal, not only you're having a hard time controlling them by approaching them each individually, but also the consequences of those diseases by staying on that person are going to create even more problems, right? So if you have diabetes, which is not well controlled, you're going to end up damaging the kidneys, you're going to end up damaging the eyes, you're going to end up having problems with their feet and with wounds in their feet and with what we call neuropathy, which are problems related to the nervous system of their extremities, right? Same thing with high blood pressure. We talked about the fact that high blood pressure can cause stroke. High blood pressure can cause heart failure. High blood pressure can cause kidney failure. So you are progressing towards a situation where you cannot reverse those diseases any longer, right? So once you have kidney failure, Kemal, that's it. I mean, the road ends there, because now we're talking about dialysis. Now we're talking about potentially transplantation, right? And where is this road starting? This road that is taking that patient inexorably towards this irreversible situation. It's starting with obesity. That's why addressing obesity is important, because now there is not going to be fertile ground for diabetes to continue to progress, or for high blood pressure, or for heart disease. And of course, Kemal, talking about diseases, we have not talked about the big C here, cancer, right? We have shown now in many studies that obesity is a ground for development several types of cancer. Several types of cancer is actually much more common when there is obesity. So all these diseases are actually the reason why obesity also leads to an early death. I mean, earlier on in your talk, you mentioned about the reduction in mortality with bariatric surgery. If you look at the Swedish obesity study, Kemal, where they were able to follow two groups of people for almost 16 years, right? What these two groups of people had in common were they were all morbidly obese. But one group, about half, about 2,000 people, underwent bariatric surgery. The other group did not go under bariatric surgery, right? They followed them. Now, the mortality, the death rate in the group that was not treated with bariatric surgery was 30% higher, right? Which means that the diseases that develop with obesity, unless they are treated with weight reduction, with bariatric surgery, will lead to an early death, not only to the presence of those chronic diseases, essentially.
So, can you elaborate the relationship with cancer a little bit? You have talked about this before, but just so that we have a better understanding, because we know the common ones and then the percentages, but the relationship with the cancer, how is that?
So that's interesting, Kemal. So there have been several studies, but these are what we call epidemiological studies, which means what we've done, what those studies have done essentially is they have looked at the background of people who develop certain cancers, whether it's breast cancer, colon cancer, uterine cancer, and others. And what they have found is that the higher the body mass index of a person is, the more likely it is for them to develop those cancers. Not only that, the reverse is true. Once people lose weight, significant weight after bariatric surgery, their risk of developing those cancers goes down as well. Now, do we know exactly how obesity actually causes those cancers? Well, there are theories. One of the more common theory is, of course, that obesity itself is an inflammatory state, is a state of constant irritation of the body, of all organ systems. And that constant inflammation may be driving these disease states, including cancer as well. So although we do not have a direct relationship to tell us this is how obesity is causing cancer, we know from these studies that the higher the weight of the person, the more likely it is that they will develop these cancers. The lower the weight of the person is, the less likely they are to develop those cancers. So now, even in cancer literature, even oncologists who talk about cancer prevention, they talk about reduction of weight as a major intervention in order to reduce the rates of cancer in that population. So,
Dr. One other condition, non-alcoholic fatty liver disease. So we also see a really good results with that. Actually, what does it mean, non-alcoholic fatty liver disease?
Absolutely.
Let's start with that.
So liver disease as a baseline, okay? If you look before this explosion of obesity in our society, the vast majority of people who had liver disease was caused by what? Excessive alcohol intake, right? So the liver is a very important organ that is involved in detoxification and also in important steps in metabolism, right? Now, it has great reserve, means You can injure the liver, you can throw a lot of toxins at it, a lot of stuff, and then it is resilient. Part of the liver may become diseased or ill, and the liver continues to function until there's no reserve anymore, and then it fails, right? Now, as I say, the vast majority of situations with liver disease were seen with people who either had excessive alcohol, or they had viral disease like hepatitis B and so on, right?
So is it more common for the alcoholic?
Oh, absolutely, absolutely. So if a person has been consuming alcohol excessively, Kemal, that alcohol is toxic to the liver, essentially, and the liver will obviously fail. So, in my training, I can tell you when I was a medical student, we had a ward back in England, which was for liver disease patients, and we had even very young patients who, and the most important marker of liver disease was yellow eyes, like because they become jaundiced, right? And the vast majority of them were there because of alcoholic liver disease, right? But now the most common cause of liver disease in our society is actually obesity. Accumulation of excessive fat in the liver damages the liver in the same way as other toxic substances like alcohol. So you develop this thing called non-alcoholic, right? Not related to alcohol, fatty liver disease. But then that can progress into a very serious type of liver disease known as NASH, to the extent that now the more common reason for people to require liver transplant because the liver has failed is actually obesity, right? And we see that with our patients very often. Very often, patients who have morbid obesity will also have some pain in the upper abdomen, and we do an ultrasound and we see, and we are able to diagnose fatty liver. Whenever we do surgery for morbid obesity, during laparoscopy, it's not uncommon for us to see a damaged liver to even very advanced status because obesity has been there for a long period of time. So to return to that question, essentially is that obesity affects the liver as well, but as long as the liver has not reached the final stages of its failure, something called cirrhosis, actually, once they lose weight, this condition resolves completely. That's why you saw in that diagram up to 90% resolution of non-alcoholic fatty liver disease after bariatric surgery.
That's amazing. So one very common condition that I always hear from people, joint pain. In some cases, when it happens with family and friends, we always have the issue of being a little bit shy about bringing up the weight problem. So because I see some people already have these issues, but then when you complain about joint pain, and you are like BMI 47, well, it would be more surprising not to have joint pain, right? So, but this is, I know now even with some of the orthopedic surgeries, they require patients to actually get the bariatric surgery first to lose weight. And in some cases, it can be eliminated. And also, sometimes, I see this issue with elderlies when once they turn to Medicare, and if they are already at the 40 above BMI, my initial reaction usually is, well, they're going to have a more difficult time with everything else that they're managing. So it's going to be more challenging. So that's why I think it's important to have this when you can, so then you are not really delaying the benefits. In some cases, the delay is going to make it maybe impossible to have the surgery because of the other restrictions that we may have. So this is the most effective way of dealing and fighting with morbid obesity. So there isn't any other efficient way to do it. And if you can actually get to this much quicker, much faster, there's no reason to delay your life, claim your life.
Absolutely. I mean, the joint pain issue is an important one, Kemal, that you bring about. But really, it's also fairly simple and straightforward to understand. Our bones, our skeletal system, and our joints are really the scaffolding that are holding our body, if you think about it, right? I mean, our backbone is at the center. We have the extremities that are connected to our backbone through joints, right? So, but they were made to withstand a certain weight, right? So, I mean, if you compare the joints of a person with the joints of an elephant, there is a big difference. The joints of an elephant were made to withstand that weight of the elephant, right? The joints of that person.
It's designed that way, right?
It's designed that way, right? So when you put the weight of an elephant on the joint of a person, it cannot withstand it. It cannot.
Yeah.
So when the weight of the person goes beyond a certain point, the pressure and the attrition on the joints, it is such that those joints are bound to become diseased, right? The cartilage can get ruined, pain can develop, right? To the extent that once the weight goes beyond a certain level, people actually become immobile. They cannot move. Actually, Kemal, it's not unusual for people who cross that 550 pound threshold. They have mobility issues. They cannot move to do simple things. I mean, let alone complex things, they cannot move. So we're not talking about pain in your joints anymore. We're talking about really being unable to move. And as humans, we have to move. Movement is essential to our being, right? Absolutely. We have to. And then you cannot do that any longer. And then there is the other side to this as well, Kemal, when it comes to joint pain. The most common treatment for joint pain in our society right now is what? Is joint replacement, right? But how many patients are denied joint replacement because their weight is so much, because the orthopedic surgeon is saying,
that's what I was trying to answer.
Absolutely, you can't. So we actually get referrals now from the orthopedic surgeons for patients to lose 100 pounds, 120 pounds before they could become candidates for joint replacement. So the joint issue is also very, very important.
Yeah. So, well, we are trying to reach out to more people and educate public as much as possible. I know we are able to get out there and then answer many questions that people have. But when it's about life, it's precious and you have to really take it seriously. The quality of life is important. And one is there are preventable issues that we can take care of, we are in charge of, we are in control of. So those are the ones that we definitely need to take care of before it's too late. So, Dr. Erkan, thank you so much for joining me, and we'll be back next week with another topic. Until then, please stay safe. We'll see you soon. Bye-bye.
Take care. Bye-bye. Have a nice weekend.